Hi, I'm Denise Willis. I'm one of the section editors for respiratory care. I'm an RT at Arkansas Children's Hospital and an adjunct faculty for the University of Arkansas for Medical Sciences. Joining me today is Cheryl Dominick from Nemours Children's Hospital in Delaware, and she's going to talk about her recent publication about unplanned extubation. She's the lead author of the May Editor's Choice paper titled Identifying Patients at Risk for Unplanned Extubation in a Pediatric ICU. And Cheryl is also the current editorial intern for respiratory care. So, Cheryl, your team developed a risk assessment scoring tool to reduce unplanned extubation. How did the decision to develop that tool come about? Was there a specific event or series of events that led to the development, or was that just forward thinking and trying to reduce and prevent unplanned extubation?
Thanks, Denise. That's a great question. So I do just want to say before I answer that this work was developed when I was employed at Children's Hospital of Philadelphia. And the tool came out really between local event review and proactive improvement work. Our team reviewed unplanned extubations that we were having in the PICU to look at common contributing factors. We also looked at some literature and existing risk assessment models. From that, we ended up adapting a previously existing tool, which was created by VATS and Group out of Children's Hospital of Atlanta. So really this work was a combination of learning from prior events and trying to be more proactive in trying to identify patients that were at risk for unplanned extubation. We did have a specific event that led to this development. We were in special cause in December of 2022, and our UE rate was 0.44. That really took us to look at it, do a deeper dive, and look at what our patients were doing prior to an unplanned extubation and what we could do to try to mitigate those things earlier.
Great, thank you. So, talk a little bit about the process of inter-rater reliability that was used to validate the risk assessment tool and how did that work?
Yeah, so we first piloted the tool in the 24 section bed of the PICU. The PICU altogether is 75 beds. So we did just a small little trial. We did it for a month. And then during that trial period, we had 16 RTs that in pairs of two, they scored up to 50 patients to look to make sure that we were scoring those patients exactly the same. So with doing that, we found that 48 of the patients were scored exactly the same. Two of the cases were scored differently, but by only by 1 point. So that really did demonstrate a high agreement and gave us confidence that we can move forward and spread the tool to the remaining areas of the PICU.
And that risk assessment tool, it was used with over 400 children between 2023 and 2024. And what you found is that it was associated with the reduction in unplanned extubation. So is that tool still currently used or has it been modified since that time?
Yeah, again, another great question. So during the study period, we implemented the tool across the 75 beds, but we did revise it in January of 24 to remove some of the subjective items. So we removed movement and agitation. Um, the goal was really to put this eventually in Epic and make it automated. So we knew that we had to remove the things that were based on, um, subjective opinion of the clinician doing the tool. So we made those changes. We continued to score the tool on paper. Currently, I have transitioned to another institution, so I cannot speak to the operational status currently. But before I left, I was working with the Epic team to try to get integration into Epic. And I do believe that work is still ongoing. I'm not sure if they went live with the Epic integration yet. I believe that they're still scoring it on paper, but they are still using it.
Yeah, I think making it electronic would be a much easier process for everyone, I'm sure.
Yeah,
And
it was going to make it more easier. And it was also the other areas of the hospital, so the NICU and the cardiac unit had agreed to use the tool once it was placed in Epic, making it easier for everyone.
right. So, Cheryl, what do you feel is the one key takeaway from your study that other RTs working with this patient population should know?
I think the biggest takeaway here is that a structured risk assessment process can still improve safety, even if it's not a perfect predictive tool. In our study, the score itself did not identify every patient who ultimately had an unplanned extubation, but I think implementing the tool alongside some mitigation actions, especially clinician alert and interdisciplinary huddles, really helped with adaptation of the tool. For me, that highlights that the tool is not just a score, but it really was a way to drive communication, shared awareness, and timely action. And ultimately, I think that is really what decreased our UEs, not really the tool itself.
Well, Cheryl, I thank you for your time today and sharing more about your work. Thank you to those who are tuning in to listen to this interview. And if you have not yet read this study, you can find it in the May 2026 issue of Respiratory Care.
Thank you so much, Denise.
Thank you.